Okay, we're going to look at fractures and bone healing in this section. On this one, we're going to go over a lot of terms, so at times you may want to pause the screen, write things down. For starters, do understand that there are many different types of fractures. They all have different names. Some are named after the way they look, named after the orthopedist that talked about it back in the day, and on it goes. We're not going to go into a lot of detail on all the different types of fractures, but I do want to show you enough to get you started with the fracture world, what they look like on x-ray, and be able to identify just some of the basics. So we're going to get into all that throughout this lecture here. And a lot of these have terms, so please know the terms. For example, here we have an open fracture, also known as a compound fracture, and this occurs when there is a break in the skin. So when you break a bone and the bone pierces the skin, that is considered or called an open fracture or a compound fracture. And you're worried about infection. There's lots of tissue damage, obviously, and these things can get pretty nasty pretty quick depending on the severity. So the guideline they go by to classify the nature of the injury, the open fracture, is the Gustilo-Anderson classification system. Okay, now on this system, I just want you to know the basics. I'm not going to split hairs with you over this. If this was an orthopedic class, then yes, we would. But I just want you to know the basics, and that is simply this. In general, now keep in mind this is in general, they classify it into 3 classifications. Okay, and in parentheses there, those are my terms just to keep it simple. So grade 1 open fracture is basically a small open wound, not that severe. I mean, granted, all the open wounds and fractures, yes, that's horrible, it's painful, it's disturbing, and all that. But even in the world of open fractures, you have your mild, and your moderate, and your severe. Okay? So that's basically your grade 1, 2, and 3. Grade 1, small open wound. Grade 2, medium open wound, and then grade 3, large and severe open wounds. Okay, here's a simple animation and some pictures for some of the different types of fractures. Comminuted fracture is where the bone breaks into several different segments. As you can see here, there's multiple fragments there. That's a comminuted fracture. So now let's combine some words here. If, let's say that the bone broke into multiple fragments and broke the skin, then you would say an open comminuted fracture. Okay, now I'm going to add a term here, and that is simple fracture, which we'll get to that in a second. A simple fracture is basically a clean break. I've got some pictures of that coming up. And then the other one is a closed fracture. Okay, so we have open fracture, bone breaks, pierces skin. And then if the bone breaks and does not pierce the skin, then we have a closed fracture. Okay, so going back to this comminuted fracture, it's obvious the skin is not pierced. So we could say this is a closed comminuted fracture in the diaphysis of the right radial bone. Okay, a compression fracture is where bone is crushed, so your vertebra can experience a compression fracture. Take, for example, like a motocross person on a bike, they jump really high, land really hard on their butt, bam, there goes the spine, negative y-axis compression, break vertebra, compression fracture. Seeing a skull compression fracture there. There's also depressed fracture, where the bone is broken inward. And then there's an impact fracture, where broken bones are forced into each other. It's like an outstretched arm, and the entire arm gets jammed into the shoulders you're seeing here. So that's an impact fracture. And then spiral fracture is basically where the bone is twisting and breaks. So there's your spiral fracture. Those are pretty nasty. And then a green stick fracture, typically you see this in youth because the bones are still relatively cartilaginous, which means they can bend. And a bending bone starts to break at the apex. So here we have bone, and it's bending, and you can see it's starting to break there at the apex. So it did not break all the way through, but it did break, and that would be a green stick fracture. Okay, some other fractures to know. A pathological fracture is where you have a break over a tumor site or an osteoporotic site or demineralization, or something is wrong with bone, structurally wrong, and because of the weakness it just breaks. Okay, that would be a pathological fracture through the damaged site. Longitudinal fracture is because the break goes lengthwise with the bone, so longitudinally. There's your spiral. Okay, spiral fracture, bone twists, usually twists, and there's an oblique line that's left. Okay, here's green stick. You're seeing the bending with the fraying at the end right there of the bone. Simple fracture is a clean break. So in general, if you're going to break a bone, this is one of the easiest forms of a fracture to get. I'd certainly rather have this over, a comminuted open fracture all over the place, just some nasty stuff. Okay, so simple fracture, clean break through the bone. Compound fracture, so here's your break with piercing the skin, also known as an open fracture, AKAs of each other. Okay, oblique fracture, because it goes obliquely. Comminuted, multiple fragments, and then there's a transverse break because it broke in the transverse plane. You might be asking, what's the difference between a simple and a transverse plane? Great question. Kind of in the same family. However, simple, if you notice up here, there is an obliqueness to it, just like this. Okay, and then in the transverse, clean break in the transverse plane. Now, I'm not going to split hairs with you over a test. I can see some of you now, like, at what angle do we say oblique versus transverse versus simple, and on you're going to go. Not going to split hairs, going to keep it simple, and we're just going over the different types of fractures. And a lot of these are also written in radiology reports, so that if you're reading a radiology report without even looking at the film, you know exactly what's going on. So that being said, if I said, this 15-year-old male has a simple oblique fracture mid-shaft, you would know what I'm talking about. Okay. All right, here's your simple, also known as a closed fracture because the skin is not being pierced. So what would you call this one? Is that a transverse? Is it a simple? I would take both. Okay, it's a fairly clean break in the transverse plane, but it's also a simple fracture because it's not fragmented, and the bone broke cleanly into two different segments. Okay, there's the first segment and there's the second segment. Okay, so in this one, you could, all the descriptive terms, you could say this is a compound or open fracture, and it's oblique. And then here's a simple fracture there in the transverse plane. Okay, some more pictures of fractures. Here's an open, there's a comminuted, and a simple. Okay, here's a real x-ray of a break. And I do want you to be aware of different parts of an x-ray. So, in a way, step one when you're reading x-rays is, what am I looking at? What body part is this? Is this the skull? Is this the pelvis? Is it a foot? What is it? In this x-ray, you're clearly seeing the wrist right here. So those are the carpal bones. Here's the thumb. There's scaphoid. And we'll get into name of all the carpal bones later on in lab once we really dive into bones. Okay, this is the forearm. Okay, and on the thumb side, you have the radius. On the thumb side, you have the radius, and on the pinky side, you have the ulna. So this is radius and ulna. You can also see the styloid process of the ulna right there. And on this side, you're seeing the same arm. So they're doing they're taking two films. You always want to take opposing views. So here we're seeing an A to P view, and here we're seeing a lateral view. So this is X-ray terms. An A to P view and a lateral view. Okay, you're seeing the radius here and the fact that it's broken. You can see the distinct break. On this view, kind of deceiving, isn't it? Where it doesn't really look broken. You can see a little irritation there, but on this side you can clearly see a more definitive break. So always take opposing views. So I would consider this a simple fracture that is closed. Okay, a Cole's fracture is where you break the distal radius, and it can be ulna as well, but in this case we're showing distal radius. So you fall with an outstretched hand and arm. Very common when we fall instinctively, we just reach out to brace our fall, and you risk breaking some wrist bones or your forearm. So that type of break is called a Cole's fracture, which in orthopedic radiology world, that one term, Cole's fracture, means a bunch of different things. Okay, comminuted, transverse, simple fracture, all that stuff is all included in the Cole's fracture. Okay, Smith fracture is the opposite. It's where the wrist goes into flexion. So there's a flexion break, and the bone will typically break that way. Again, that's the distal radius. And yes, the ulna can break as well. So this is a Smith fracture. Okay, an inversion fracture, you're seeing the ankle inverting, and you can certainly break bone doing that. So here's the calcaneus, that's your heel bone. So this right here is a posterior view, and here's the distal tibia and the distal fibula, and you're seeing a break in that distal fibula and then a break here in the distal tibia. Okay, this is a common presentation with an inversion fracture. Okay, your classifications of your ACL avulsion fractures. So two terms here, ACL, anterior cruciate ligament. So that is one of two special ligaments in the middle of your knee. You have the ACL and the PCL. And avulsion, the other term I want you to know, means that bone was pulled off of itself. Okay, so muscle tapers into a tendon and attaches to bone. And sometimes the muscle contracts so hard that the muscle didn't tear, the tendon didn't tear, it just tore bone, pulled a chunk of bone off of itself. Ligaments can do that. So here we're seeing an ACL. The connection of the ACL ligament into bone was very good, very tight, very strong. And the nature of the injury, so the ligament didn't tear, it avulsed the bone. So here we're seeing a bone fracture, okay? And depending on the degree, type 1, 2, 3, and 4 is going to be how they're going to classify it. So your usual suspects, typically a class 1 or a type 1 is mild, and the bigger the number means severe, okay, and everything in between. So type 1 would be a minimal avulsion fracture, and type 2 a little bit bigger, type 3 a little bit bigger, type 3B bigger, and then type 4 fragmented. Okay. Here's the lateral collateral ligament, your LCL. Okay, so here's patella. This is the distal femur. Seeing some articular cartilage there, meniscus, tibial tuberosity. So this is the proximal end of tibia, and the quadricep tapers into a tendon and attaches right there on the tibial tuberosity. We'll talk about that once we get to some other parts of bone and then muscle. Okay, here's the proximal end of the fibula head, and the lateral collateral ligament does go from femur to fibula, and for whatever reason the movement, the contraction and so forth was hard enough to not tear the ligament but avulse the bone. So there's an avulsion fracture. Okay, over here you're seeing this on x-ray. So here's a to P, here's patella, distal femur, proximal tibia, proximal fibula, fibula head. On the A to P view, don't really see much. I mean, certainly you can see it there, but at a glance you're like, not much. Lateral view, lots of stuff going on. Always take opposing views. Okay, there's patella, distal femur, proximal tib fib. There's your avulsion fracture. Okay, here's an x-ray of pathological fracture. Again, x-ray rules. Number 1, what are you looking at? Here we're looking at a shoulder. You can see a little bit of the ribs. Okay, you can see the outline of the scapula. There's clavicle, and there's the humeral head and the diaphysis of the humerus. So we're looking at a shoulder. And look at the cortical margin of this humerus. You can see it's obliterated. There's bone cysts in there. It's got a lot of gray spots that you should not normally see. And here we have the fracture. So because of the bone injury here, there's a pathology, a lot of bone cysts going on. This bone is now weak, and this person has now broken the bone right there. So that would be considered a pathological fracture. Okay, what are you looking at? This is another shoulder, humeral head, part of the scapula. Here's clavicle. There's ribs, a little bit of lung shadow, cervical spine, and this white stuff you see here, that's soft tissue, skin, and all that. This looks like a young person because of the growth plates, so youth. And we're seeing a break in the clavicle. So there's a mid-shaft clavicle break. Does not look like it's piercing the skin, and a fairly clean break right through the mid-shaft there. Okay, now here's one that's a little more complicated. It's still a shoulder. Here's clavicle. This looks like an adult. I do not see growth plates or the epiphyseal plates. And so here's a mature skeleton, but there's the clavicle, and this is a comminuted fracture, I would argue, because it's broken into more than one fragmented pieces. Okay. Fracture of tibia. So there's a transverse fracture, spiral that went through both. Pretty nasty comminuted break there. And then here's a segmented fracture. These are definitely orthopedic repairs, plates and screws, and every surgeon's a little bit different on what they choose to do. Depends on the age of the person and a lot of factors that they take into consideration, and then they'll do the best work they can to get them better. Now, of course, as a bias, once they're done with the orthopedist and the surgery and they're well into their recovery, then that's where your rehab and PT and so forth is going to come into play, and nutrition to get them better. Okay, this is a lower leg, so here's the tibia, there's the fibula, and you're seeing a break through the tib fib. Looks to me like it's closed and simple. You might could say transverse. Okay, stress fractures. These are fractures because of repetitive motion. Now, we'll classically pick on your shin splints and the foot. Okay, so lower leg is a common area to get stress fractures. Now, this one says stress fracture of the talus. Talus is an ankle bone. We'll learn that later. It's the bone that connects to the distal tibia that allows you to do dorsiflexion and plantar flexion, which is what this person's doing here. Dorsiflexion, the foot goes up. Plantar flexion, the foot goes down. That repetitive motion over and over and over again, especially with impact and weight bearing, can cause a stress fracture to the talus. And one of the other causes is because of repeated overpronation. Now, I am a sports medicine person. I'm really big into human biomechanics. And so one of the biggest and important features to look at is the foundation, your foot. Is your foot flat? Is it pronating, overpronating? Is it supinating? Like, what's going on? High arch. There's 26 bones in the foot. Lots of mechanical behavior the foot needs to go through. So if a person's walking or running, doing sports and activities, and there's this abnormal biomechanical repetitive motion over and over and over again, you're going to get a problem. Whether it's plantar fasciitis, stress fractures, shin splints, and on the list goes. And we'll dive into more of those conditions later on. Here's a teaser to that. I do want you to know that ideally you want the foot to be in a neutral position. Okay, the foot can handle a few degrees of plus or minus an error here and there, but once it crosses a line and gets excessive, you're going to get overpronation or oversupination, and it's going to lead to a lot of problems. Now, most people have this problem. It's overpronating. And over time, especially as we get older and the more miles we put on our body, the foot just flattens out, the arch falls, it collapses, and you get pronation and overpronation. When that happens, you get a pretty aggressive, abnormal biomechanical kinetic chain of events that goes from the bottom of your foot all the way up. All the way up. Foot, ankle, tib fib, knee, hip at the femoral head acetabulum, hip at the SI joint, sacroiliac joint, lumbar spine, as it attaches to sacrum, and of course thoracic spine, and then cervical are all connected. And later on, you'll see what that looks like as we really start piecing everything together. But just know that a foot problem can cause a whole slew of other problems. Okay, so over here you're seeing evidence of X-ray of stress fracture in the bone. So you're seeing, here's the calcaneus, there's the talus, and other tarsal bones. You'll learn the names of these later. Keep in mind, muscle tapers into a tendon and attaches to bone, right? That's the antithesis. And excessive pulling on the periosteum of bone creates micro tears, and now you have an inflammatory response. With enough inflammation, remember, calcium is always mobilized with macro and micro trauma. So you're going to get an influx of calcium to the area. So now you're going to get a high signal, which you're seeing here on the X-ray, a high signal. And micro tears in bone. This is your so-called shin splint / stress fracture to the bone. Okay, so this person, now this is on the posterior aspect, so this is likely the posterior tibialis muscle that happened, but sometimes it happens in your shins and the anterior tib and some other muscles that excessively pull on the bone start to create shin splints. So your solution to this problem that nobody wants to do, because we're dealing with athletes and active people, is you have to rest. Do your RICE protocols: rest, ice, compression, elevation. That starts to get the inflammation under control. The next thing to do is adjustments. Get the bones in alignment. Now, nobody does that but chiropractic sports medicine people. The best surgeons in the world, they don't do that. In general, PTs by themselves don't do that, but your chiropractic, PT, sports medicine people, they will, and that's what I do. And I do a lot of it, and I'm very good at it. And we get the alignment in the foot bones and the tib fib, knee, hip, all that. Get it realigned, get it straightened out so you're not running on a crooked bones anymore. Evaluate the foot. Get a custom-made orthotic. I make orthotics for people. You can get those anywhere. There are some that are better than others. I like the Vasili brand. We mold them here at my office and get them in your foot or in your shoe so that it corrects the abnormal biomechanics as you're seeing here. Okay, we get you to more of a neutral foot. And then I like kinesiotaping. So a lot of kinesiotape will go over the hurt site, electric stem, soft tissue release, dry needling, tons of wonderful physical therapy and modalities and adjustments to do to get you better and stay better in the long run versus this constant, ridiculous symptom management. It hurts, and you play through the pain. And everybody goes and sees their family doctor or someone like that, and they just do pain meds. That is doing nothing to correct the abnormal biomechanics. That is the problem. Abnormal biomechanics, misalignments, overpronation, etc., etc. Get that corrected, and you've now corrected the problem. Okay, a stress fracture falls under the same thing I just mentioned on the prior slide. Has to do with abnormal biomechanics, flat foot, pronating over and over again, and the stress starts to go to one of the metatarsals. Okay, so these long bones here, these are the metatarsals. Okay, we're looking at a foot. This is a top view of the foot. So right up here, these are the toes, so your phalanges. These are the metatarsals, those long bones there. These are the tarsals. Okay, so we'll learn this later, but quickly: tarsals, metatarsals, phalanges. This one is the great toe, so that would be your big toe, and then digit number 2, 3, 4, and 5, the pinky toe. So on this one, you're seeing metatarsal number 2 is experiencing a stress fracture, also known as a March fracture mid-shaft. And I've actually had this. Years ago, I ran. I was in San Diego, ran on the beach, and was barefoot. And anyway, long story short, I started to feel this pain in my foot. Now, keep in mind, I do have a flat foot, so I do pronate. So I wear orthotics, and it helps me tremendously. But at the beach, so I'm running barefoot. And also, if you ever look at a beach, especially right up next to the water, it's not perfectly level. There's always an incline to it. So if you're running one way, your feet are tilted, inclining, both of them to the right. Or if you're going the other way, they'll be inclining or kind of tilting to the left. And now I'm running on double abnormal biomechanics stuff. So, and also I'm at sea level, and I'm used to running at altitude, so I was feeling great. I mean, you talk about training at altitude and then going to run at sea level. A remarkable difference. I mean, I could have gone forever. So I did. I just ran forever. And I paid the price later, and I did the usual suspects where you start to feel something, and you're like, whatever, push through it. Plus, I had my so-called runner's high, the endorphins, your blocking pain and all that. But boy, I paid for it later. Ended up getting a stress fracture in, it was actually my third metatarsal right there. In this x-ray, they're showing the second metatarsal. So poorly fitting shoes, flat foot, and on you can go with abnormal biomechanics can cause a stress fracture in the foot. Okay, do you know the stages of healing of fractures? So when you get injured, meaning a break, the first thing you're going to get is pain, swelling, lots of bleeding. Okay, pain, swelling, lots of bleeding. So hematoma formation. And then sometime later, you're going to start to get fibrocartilage that's going to come in to start to splint the bone. Okay, we're laying down a framework. Tissue is beginning to repair. Swelling is starting to calm down. New tissue and its formation process. Phagocytes. Okay, phagocytes are a type of Pac-Man, and they are going to come in and eat the dead and dying cells, your broken fragments and so forth. They're going to go in and start cleaning things up. And it's going to prepare the area for connective tissue repair. Okay, in the third phase, you're going to get the bony callus formation. And this is where the osteoblasts and clasts are really coming in, doing their job. Remember, osteoclasts break down bone. And you want this in this case because we're going to smoothen things out almost like you're sanding something down. Very coarse, you want it smooth, sand it down. Okay, osteoclastic activity. And then the osteoblasts come in to start to build. So this is our bony callus formation. And then in stage 4, we're getting the bony remodeling where calcium is going to be deposited into that fibrocartilage matrix that was forming, and the remodeling takes place. Okay. Now, depending on the age of the person, pre-existing conditions, nutritional background, and all that, the severity of the injury is going to depend on how long a fracture is going to heal. So when I visit with people that are coming to see me post-fracture, I'm taking a look at the x-rays and, whatever they went through. Did they have surgery? Do they have hardware? How long was the joint or area immobilized? How old's the person? What's their activity level? All that stuff. Okay, so you take that into consideration, then you come up with a game plan to help them get their range of motion back, help them get their function back. Okay,